So we're going to start with Ed and the kind of global topic of monitoring groin injury risk, and get your insights, get your experiences, and then the guys can weigh in as well.
Yeah, sure. So I guess a lot of my past sort of experience has all been in ice hockey. I was in rugby as well for 10 years before, but a lot of my reflections and practices are based in hockey at the moment. And the first thing that we would always do when our players return to us after the off season is put them through a hip and groin kind of screen to identify, which players we need to create an intervention for and be a bit more diligent on our monitoring strategies. So we'll put them through a strength test, adduction and abduction testing. I know Steve's going to talk more details about that later. So strength testing is obviously one of our first things that we look to identify. So we'll look for some ratios and some absolute measures as well, obviously overlaying with some previous history that we know from previous seasons from our players. We'll also put them through range of motion assessments, primarily internal hip internal range of motion and external and abduction. So we have certain thresholds which we deem to be important that we keep our athletes in and around. And that's kind of our starting point for identifying, what type of training modalities we'll need to include into their pre-activation routines as we go through the season. And we're going to obviously be trying to correct some of those weaknesses or lack of mobility and imbalances as we go. So that's kind of our starting point. And then I guess for hip and groin monitoring for our population of athletes, having a robust training load framework is critical. And there's a few reasons why it's important. I guess this is a universal thing for most team sports, but the highest risk in ice hockey for adductor strains or hip and groin pain dysfunction is normally as we go through pre-season and transitioning into the in-season phase, where we're at such a great risk of acute changes in training load. So our starting point is always having an external load measure that we can monitor, short-term and long-term monitoring of an appropriate external training load. For us, that's player on ice load. And we put that into our framework so we can see, short-term changes relative to the individual, and then interweave it with our more medium to longer-term changes. Are we seeing these spikes reflected in what they're prepared for with things like the acute to chronic workload ratio? So a training load monitoring strategy is critical for our athlete population as we transition through the different phases of the season, because we'll go from our athletes coming from the off season, which we have no control over, to our coaches wanting to impart a significant amount of sports specific load. And then all of a sudden we go into gameplay pretty quickly. So that's critical. And then as the season progresses, it's also important that we individualize our training load monitoring, because ice hockey is a sport where we have very different workloads achieved on a daily basis based off position, based off the line that they're playing and the importance of that player. So we need to make sure we have a really good understanding of what their kind of acute load is, what that load looked like for each game. So we can see, was that individual, even though we can collect minutes of work, but was that minute of work, those minutes of work in that game higher or lower relative to their game average, and put that back into our training load framework to see if we have to incorporate any extra recovery modalities, or if we have to adjust the training load on the ice via practice reps, or we have to give them something off the ice which is going to help regenerate them. So that's one of our kind of like daily streams that's critical for us to identify risk of overreaching and how that's reflected in the hip and groin region with our players. And then I guess if we kind of peel back to off ice metrics that we like to collect, the easiest one for us, which I think has big impact, is, and it's a low intensity measure for our athletes, is trying on a weekly basis to get a feel for what their range of motion assessments are. This seems to be very sensitive to workload, and we can also make adjustments if we identify risk pretty quickly with modalities of training like pails and rails around the hip, IR, ER, and abduction exercises. So we have a very good medical team here who can collect that information on a weekly basis for us, and that feeds back into our monitoring system. I also am a big fan of using off-ice counter movement jump for fatigue monitoring and neuromuscular freshness and status. I think that can help us understand, particularly if we're looking at a movement strategy as a metric output, how fatigue is manifested. Are they changing their movement patterns? and is this a risk factor potentially that might translate into their on-ice skating performance? And then, this is something that we would like to do more frequently. It's harder to do, but obviously getting strength assessments and revisiting those adductor strength measures, the abduction strength measures on a more frequent basis, if that's monthly or bi-monthly, that's valuable. We know that if we start to see a decrease in strength capacity, particularly in the adductor region in ice hockey players, that could be, the sort of the preceding warning signs that we might have some kind of an injury risk happening in that area. But practically, it's harder to achieve. I've had seasons where I've been more successful than others getting those kind of measures in place. But it's definitely valuable if you can manage to get it into your environment. Obviously, there's a higher intensity load associated with performing those kind of metrics. And then finally, I guess moving more into the sort of communication and subjective realm, I have huge value in just having a close relationship with our athletic training staff and particularly our massage therapists, where we know what the cadence and frequency of sort of soft tissue treatments are for each player. And if any kind of player starting to increase their frequency of particular work around the hip groin region, that's valuable information for me then to start digging a bit deeper to see if are they getting into more of an overreach state. Do we need to talk to them about increasing some recovery modalities? Do we need to pull back on the ice with their workload? So even though that's not a measurable, it's a really valuable piece of information to have on a daily, weekly basis, getting that feedback from how much work these players are getting from the treatment table.
Perfect. Great place to start, Ed. Thank you for that. Just on that sensitivity of the range of motion assessments that Ed had mentioned there. Is that something that you find, Steve, in your population?
Yeah, I think the range of motion and the changes between competition and then the changes over the course of a season and the changes over a course of career can paint a really interesting picture. And just like Ed was saying, I think you want to stay ahead of those trends and identify them and intervene versus being in a position where you're looking back and wishing that you would have picked up on that trend, excuse me, a little bit sooner. And so with the range of motion, I think that's one of the easy, quick turnaround signs. If you're having hands on a guy and you're seeing them relatively consistent, hey, that's a little bit different, unusual. How is this matching up? Am I talking with my other colleagues, massage therapists, strength coaches? Are they giving me subjective feedback that matches? Like, hey, that's tight. Now we get a goniometer measure on that. That's different than their baseline. And that just sets you up to intervene a lot sooner.
Perfect. Thanks, Steve. Anything different that you've done, Enda, or anything to add? Or
no, very comprehensively. I think, as Ed has highlighted, there's the three parts of kind of load, function, and tissue tolerance, and you're trying to keep an eye on all three. And depending on the athlete or the stage of the season, some parts are more important than the others. So it's having that broad overview, and then especially the preseason challenge is the preseason challenge, no matter where you are in the world. So it's how can you build in that wiggle room. How much is good enough it's an unknown. So as Steve said, you're trying to cover all your bases and give yourself that breathing space to hopefully get through that intensive block.
And just staying with you for a second, when it comes to these range of motion assessments, you've worked with athletes from 1,000,001 different sports. Is there any nuances that would change depending on the type of sport, the type of athlete, or would it very much be quite global in terms of what you do in that area?
Yeah, I don't tend to see, specific range of motion deficits to a sport. Within a sport, you get huge variety and across a player's career, you get changes as well. So it's not like, let's say, to use an exaggerated, pitchers in baseball, where, there's a very clear, long-standing change as a correspondence to that load over time. In lower limb injuries here, which is predominantly ice, court, and field sports, you don't seem to see a natural trend towards either asymmetry or certainly restriction at X or at Y or at Z. I think sometimes clinicians go down, it's a football specific injury or they're footballers, therefore it's this. I think sometimes you narrow your microscope at the beginning as to what could be contributing. So I go very much on an individual basis, start with a broad assessment and not get too narrow on the sport specific component of it first. it's very relevant when it comes to the load components, the sport specific components later. But I'm slightly biased in that I usually only get them when they're injured as opposed to healthy, and trying to mitigate against that. And so the broader that initial assessment is, probably the more likely you are to identify all the contributors.
Perfect. Thanks, mate. I'm fighting myself here because you've mentioned asymmetries. Now, I like structure and I want to keep to our structure that we've come to, but you've mentioned asymmetries, Enda. So I'm going to come to you, Steve, next to our third point, even though it's the second one mentioned, and say the impact of asymmetries. There's so much talk around asymmetries across all sports, but what's your perception of the impact of asymmetries, Steve?
Yeah, so symmetry, it's beautiful to look at, right? We love the eyeball test of something in nature and just being perfectly symmetrical. But even just like looking at the human skeleton and bony changes and just appreciating that no human being, just from a basic anatomical standpoint, is perfectly symmetrical. And then depending on the sport and your evolution over time and how much activity you had as an adolescent and going through and evolving into adulthood and the demands of your sport, if it's like an art sport and you're having more rotational demands versus maybe some of the court-based or field-based where you see maybe some less range of motion, and that's establishing a normal range of symmetries for that population that you're working in. And so that's a comprehensive profile of just where you're starting out. And then you get into measuring either range of motion, measuring strength, and you have to appreciate what is normal within that. And so I think when you're appreciating symmetries, it's important to realize that when it's really out there, it's a really big sensitive flag for you, and it's something that you can probably work on. And at the same time, as you can see from some of Enda's colleagues' works with hop testing and things like that, that just because you have a good limb symmetry index, be it range of motion or just strength, it doesn't mean that you're in the clear. So if there's a big white whale and it's telling you something, we have a 50% asymmetry, let's dive into that. What is the cause? Are we acutely in pain? Is this chronic changes that we're offloading? That's something we want to dive into. When we're closer to 5, 10, 5, 15%, be it strength, be it range of motion, it doesn't mean that you're good, but there's a healthy appreciation. So that's the magic bullet. And I'd love to hear what everybody else has to say about the cascade of symmetry.
Who wants to weigh in? Ed, any thoughts? Enda, go.
I'm
Sorry,
sorry, there you go.
Don't be too polite. Ed, go first.
I kind of with Steve on that. It's I work in a rotation sport that loads up one side, from a shooting perspective, and it's trying to identify what we feel is sort of a healthy asymmetry that they can operate with from a performance perspective, and then where it drifts into the risk factors. And Steve sort of mentioned there 20% plus type areas, particularly coming back from injury, you want to get them back into the territory that might be more sort of 10-15% or lower. Those are those sort of make sense in my mind, and I don't think it's exactly where exact science in terms of a threshold, but it's about being able to identify what we think is acceptable and normal for them to perform at, and then what kind of drifts into that massive sort of risk factor that we can work on if they are injured during that rehab phase. And I see it with hockey players; they've all got asymmetries when they're performing either a counter movement jump for any kind of neuromuscular output, or if it's a range of motion assessment. And range of motion in particular, we'll definitely try and work on. But we're kind of happy if we get them, within a sort of a level where they're close to where they're at baseline asymmetry differences, and when they were performing to a high level. I would say it's definitely not an exact science.
Enda.
Yeah, I'd agree with all of that. And I think, how much asymmetry is too much asymmetry goes back to the other components of training load. So obviously the higher the spike and the change, very often that will influence your wiggle room, or the bigger the changes in anatomy, if you have large car morphology on one side versus the other, or bilaterally, so there's a host of things that contribute to that. I think very often with groin pain, there's a main side. There's a side that your symptoms are predominantly on, and very often functionally there's a side that's the driver. So at least in rehab, you find that as those asymmetries resolve, their symptoms tend to transition with it. So I think through a rehab block, you tend to see that. The question is, in a healthy population, how much is too much, and there's no right or wrong answer. I suppose the more evenly we distribute both sides, the less likely one is going to be the victim, so to speak. So I think definitely in a rehab point of view, generally if you see those asymmetries resolving, that you get a concurrent change in symptoms. But in a healthy population, it's like asking how long is a piece of string. It can be quite a challenging landmark to highlight.
Do you think it's something that we've gone down the rabbit hole too much in?
No, I think it's like everything else. If you say black, someone will argue white. So there's a lot of discussion for the sake of discussion. To be honest with you, probably too much debate. In an injured population, you want to get it back. Especially again, I'm biased by my practice. You're getting the ones who are struggling to get back, maybe a little bit more chronic. If Anthony, you want to overdo it, you want to give them extra wiggle room and extra robustness. That's different than, let's say, the environment the guys are working in, where and also like asymmetries may be transient. I pull up a bit stiff or tight after the game last night. I rolled my ankle a little bit, everything's a little bit inhibited, and then 2 days either both through soft tissue or just generally moving, that just eases out and goes again. So what's a true asymmetry versus I'm stiff getting out of bed this morning? So I think there's probably a little bit, we have to be talking about something, so therefore it goes too much. I'm biased in that definitely groin pain in the more chronic sense has a side that's generally the driver, whether your symptoms are right or left, and that's often by differences in control or strength or whatever function one side versus the other. And as those differences resolve along with load management, they tend to come back together. So I think it's there's a reason you get sore on one side, or the majority of the time you get sore on one side, and that side is generally, in relation to the way I move one side versus the other. So assuming the amount of skating or running or whatever load is the same, why is one side becoming the painful side? But in a screening kind of how good is good enough, I think it's you give yourself thresholds and then work from there.
Yeah, and I would just like to add on to Enda of you want to take that symmetry or asymmetry in context, because when we're rehabbing and it's resolving and we're getting closer to normal, we might be really happy with, we might be 100% symmetry, but then your symmetry might be within a baseline. Say if you're talking strength, if it's my squeeze is both 100 newtons on each side, well, yeah, I'm 100% symmetrical, but my baseline, I'm not robust. And so I'm going to need to elevate that and zoom out of the symmetry context and look at the bigger size picture and take the symmetry for what it is.
Perfect. Cheers for waiting there, Steve. Thank you. We've got one question and we're only 21 minutes in, so I love that. So keep the questions coming rather than wait until 10 minutes to the end, because we just won't be able to get through them. And please mention who you want that to be guided towards. So we're going to come back to question 2, even though I've done question 3. Strategies for mitigating the risk of groin injury, and this is one again for you, Enda, to start a little bit of a conversation.
I apologize for messing up your well-laid plans.
No, it was me. I jumped on the A word. I jumped on the A word, and I thought we'll attack it there.
Look, I think a lot of the strategies for mitigating follow in with the points that all the guys have made earlier on. I think your number one thing is to flag your high risk players. There's obviously high risk stages of the season, which will be pre-season, as Ed has highlighted, but definitely those that had groin pain last season are much more likely to have groin pain in the subsequent season, irrespective of sport. So whether you're scanning or reviewing or screening of them is more frequently during that period, I think that would be number one. I also think it's very interesting that what Ed highlighted was that very often they'll feel there's little warning signs that they'll feel a bit tighter. They'll feel they're not injured, they're not in pain, but they know that it just doesn't feel normally in advance. So having a good discussion with your players about, if you feel anything, just flag it early. We don't need to change anything. You don't need to step out. You're not injured, but we can be a little bit more proactive in how we get in there. And that is also complemented by your pain provocation test. So there's a number of ways of provoking pain in the groin. Squeeze with your legs straight or at zero is normally the greatest leverage in the area. So often it's the most provocative. And very often it will become symptomatic before they report symptoms playing. So they'll feel a bit of discomfort on a long lever squeeze, despite having pulled up or not reported have any pain later on. So I think keeping an eye on those three are one way of mitigating risk and complementing what Ed has said earlier. I think that this second part is that when you have your drop off on your markers, whether that's range of motion, whether that's hip strength, whether that's some of your functional tests, is digging into the why of that now. So if I have a drop off in adductor strength, is that because my adductors are weak? Is it I'm fatigued? Or is it, I lack that trunk control, or maybe my obliques on one side have over time, especially let's say the likes of ice hockey, you're getting bangs and bruises and you're getting stiff and inhibited all the time. Is that starting to accumulate versus my adductor numbers are down, therefore I'm adductor weak? You may well be, but a lot of the times you may not be. Similarly for your hip abduction strength, so a bit like the cuff and the shoulder, if your glute min has got sleepy or lazy, your deep rotators have got sleepy or lazy, your ability to generate force at higher intensities is going to be inhibited, and similar with your loss of hip internal rotation, how much of that is a joint stiffness versus a muscular tightness, to give it a very broad generic phrase. So trying to dig into, okay, I have a drop off in a marker here, whether that's range, whether that's strength. I need to dig into now why that marker has dropped off. And it may not be just in isolation to that muscle group. There may be a combination of components that are contributing to that. And I think, as the guy said, maintaining that range of motion, and identifying quite quick, certainly, especially in healthy populations, there is a natural history across sports of soft tissue work, both as recovery and as a way of reducing soreness and any particular tightness. But I often think that tightness is it's very useful information. So tying back in what Ed had said, if I'm tight in a certain muscle group, is that muscle group the problem, or is it tightening in response to something else? So I think the regular screen of your high risk patients is important. The regular screen of your pain provocation test will give a little warning flag. But when you do see a drop off in a marker in a healthy athlete, to dig into that a little bit more and see, is it more local in terms of deep muscles of the hip or trunk muscles that are contributing to that more superficial large muscle hip strength deficit, or is it something that is just fatigue and something that's just inhibited because of the playing schedule or any bumper bruises they picked up recently?
I know this is going to be very much dependent on which and by how much, but is it always the case, or never the case, that players should be pulled from training if some of these markers are down? How do you understand where to go from there?
I think that the guys will speak better to that in terms of in season. I think where I see players is they haven't listened to their pain. So like if you're in season and you're hopping your head off a wall, there's only one winner there, and your groin is the winner. So like if you have a player that's pulling up sore after sessions or the morning after in pre-season and the early part of the season, the chances of them getting to the end of the season without a drop off is almost zero. If you have a Champions League final this weekend, you play the Champions League final and you worry about it afterwards. So it's a different set of rules per se, but certainly I think you need the mentality: am I looking to resolve this problem, or am I looking to manage this problem? And either which way, you probably want to see at least a holding or an improvement of my pain provocation tests over the course of a week. If my pain provocation tests are dropping off week on week, that's only going to end to a point where the player is too sore to play, or the performance is inhibited to a point where they get pulled regardless. But I think the point for pulling a player is perhaps something that Ed and Steve could refer to with greater frequency.
Anyone want to weigh in? Ed?
Yeah, so we would, like what Enda was alluding to there, kind of the first kind of port of call would be to pull back from the provocative load, which is the on ice component, and we more often than not feel that pulling back from that and then taking them through treatments and kind of giving them the recovery time will allow us to get through that kind of soreness, and then we can manage our players through the high density game schedule. I think a lot of what we find is we get early warning signs before more of a catastrophic soft tissue event. So we'll always kind of take the stance of being more conservative, reduce their training load, take them out of practice, and then try and put them through more reactivation type protocols, which we can achieve in the gym, because more often than not, we've we've identified the issue before it's become technically a time loss injury. And again, Enda was kind of alluding to identifying whether there's inhibition through the trunk or around the pelvic region due to some contact situations, or whether it's an overload type situation. If we can try and kind of identify where the kind of loci may have stemmed from, then we can put in place some activation exercise strategies which might be beneficial to get this player pain-free, improve their function, and then get them back into the lineup pretty quickly. And that's kind of how we would operate to try and make sure that we make them available for games as much as possible. Obviously, taking them out of gameplay is the last resort for us. We'd always try and reduce their practice load, identify what window we think we need to address, whether it be more of a localized structural type of training stimulus, or whether it be more kind of intersegmental type of training and reactivation type training alongside the passive therapy to help reduce their inflammation and their pain. So yeah, that's kind of how we would approach it.
Just out of interest, Ed, what percentage of games lost, hours lost, minutes lost is groin related issues at your place? Or ice hockey?
Quite low.
Okay.
Yeah, quite low in terms. Well, again, it obviously it differs depending on the organization and the year as well, and also kind of the type of athlete you have, the age of the athlete, the experience of the athlete, how much previous injury they've had. But in general, athletes will be playing with pain, discomfort in the hip groin region rather than time loss with the hip groin area. Obviously, there are time loss injuries through impingement, FAI and adductor strains, and athletic pubalgia and pubic symphysis stress responses. But in terms of the time loss, if you are proactive, as we're talking about today, I believe that you can keep that man games lost from these types of injuries very low, because you can manage your players through dysfunction, through pain, and keep them playing. Now, obviously, do we have players that are playing NHL games with pain and discomfort? Absolutely, we do. But our goal is to get them out there and then trying to reduce that pain and dysfunction as much as possible in between games. So yeah, there are times. Obviously, there's a percentage associated with time loss of these types of injuries, but it's also a region and an injury area that we can manage our players through and keep them playing.
So as Enda said, it's very much a manage versus resolve in season.
Yeah, I think like Enda and Steve have both alluded to, identifying the red flags as early as possible, and then identifying the risk mitigation strategies, both passive, active, training load orientated, and then attacking it aggressively to try and keep the players out there.
Thanks, Ed. Anything differ in this aspect for you, Steve?
I think Ed said it beautifully. The one thing I could add is I think you're always considering the person and everybody that has a piece of this. So the START framework is really great, where you're just assessing risk. And that might not necessarily be quantifiable, but you're having good communication and dialogue with mainly the athlete and then everybody involved with that, making sure that they're dialed in with the plan. This is what's going on. These are our assessments. Are you comfortable with this? We're all geared up. We're all swimming in the same direction. And then you keep them out on the field.
Perfect. Right. I'm loving this because there's loads of questions.
I will just jump in quickly.
Oh, go on, Ed.
Sorry. Yeah, just to add on to Steve that, we actually, we do keep, like, we kept the player out, recently for identifying that, we maybe needed more time. And Steve works in basketball and I'm in hockey, and our game schedules are just so crazy frequent, and, and they come at you so fast. So there are times where you do, decide to keep a player out of a game to ensure that they're back for the next 10. So those do factor into your management strategies as well.
Of course. Thanks for that, Ed. Just back to my delight at all the questions that are coming in. Makes my life a little bit easier. So we'll maybe finish these list of questions that we've got pre-prepared a little bit earlier to dive our way through, and some are right on topic from some of the stuff that's already been chatted about. So that's great. Enda, you've mentioned once or twice around looking up and down the chain to understand groin issues. Can you explain the process you would go through to do that?
Yeah, I think regardless of whether you're pain, I mean, you can have bilateral pain, but very often it's unilateral source of symptoms. So regardless of whether your pain is left or right side, there's normally functionally a side that's driving the problem. And so, for example, if you're overloaded through your adductors on your right side, you know, how much of that is a stance leg issue, whether that's frontal plane control, etc. And obviously, while the hip is a massive component of your frontal plane control, your foot and ankle is also a big contributor to what goes on there, and it's not infrequent, probably more so in football than in ice hockey, maybe basketball a bit as well, where you'll have had a player's had a ankle injury, maybe a syndesmosis, gets quite a bit of inhibition afterwards, starts to come back, and next thing the groin niggle starts to come back, or starts to come as they re-enter, maybe a couple of weeks back into reintegration. So I think when you're looking at, we've talked about kind of control around the hip and around the trunk, but as we go more globally, as you start to have activities that provoke them, perhaps jumping, landing, running, change direction, within those patterns, both proximal and distal to the hip, there are contributors to why you're moving the way you move. And if I focus only on, again, I'm biased probably more in the more chronic presentation, the more difficult ones. If I focus only on the hip, 80% of the time that'll clean it up. But there's 20% of the time where dysfunction, proximal or distal, may be a greater contributor to what's going on, or maybe driving some of that hip inhibition. And so it's something to look at. And similarly, if you look at the swing leg, whether that's someone that gets groin pain kicking or running or sprinting, how much of it is the stance leg, but how much of it is my trunk control and rotational control. And again, you'll see more in contact sports where players have had a shoulder reconstruction. They go to come back very often. They get back running early with the arm in a sling or just out of the sling. The rotational deficits. The next thing, they're starting to overload as a result of that oblique or trunk or even shoulder dysfunction as well. So I think the guys have outlined really nicely some of the key movement patterns and restrictions to identify. But then once you've identified them, taking a more global approach, both in terms of individual mobility and function at a joint, whether that's trunk, shoulder, or ankle, for example, but also then expanding that further as in how is that control, how are those joints moving during higher level activities that very often the athlete is describing as provocative.
Anything different there based on the kind of biomechanics of your sport, Ed?
No, again, there's a lot of global crossover. One thing Enda mentioned there, which is really important for hockey, is this sort of segmental coordination of the trunk. Particularly we're a rotation sport. How the trunk operates in relation to that kind of lumbo-pelvic region is a lot of the reason why we get sort of these transferring overload-based injuries in the hip and groin area. So that's a training modality that we certainly have regularly in our activation strategies with our players in between games. And it's a big part of when we would rehab a player, we introduce that and we build upon that with different types of velocity loading schemes, intensity loading schemes. But yeah, that kind of trunk rotational control and how that impacts the hip is critical for us.
Perfect. Right, we're going to move swiftly on because the questions keep coming in, which I'm delighted about. So Ed, and this is going to be I'm going to put a time limit on you, a made up time limit.
Yeah,
that's fine. A couple minutes, short journey through a groin rehab that you've had lately.
Okay, I'll fly through this. We'll sort of assume that maybe this is an adductor strain, as that's our most common kind of rehab strategy. So I kind of break it down into 5 phases, and there's a lot more detail to this, obviously. But the first phase would be an isometric and pain kind of reduction phase, where we also focus on restoring mobility. So multi-joint isometrics around the hip, yielding and building down into more overcoming, but trying to regain some neuromuscular activation at different muscle lengths. We'll also have some glute kind of activation and posterior chain band work, that type of thing, and maybe bring in some body weight BFR type compound movements to lay the foundation for phase 2, which will be moving more into isotonic strength development. So we'll incorporate more, split squats, lateral frontal plane loading, so lateral squats, lateral lunges. So we're starting to lay more of a foundation of strength, multi-plane strength with unilateral movements. This is where what Enda was just talking about, and I alluded to with segmental trunk control, trying to make sure we're training trunk appropriate mechanics with trunk flexion, rotation, side flexion, and how that impacts the pelvic region. So Palloff presses and med ball rotation work, things like that will come into play here. And we'll start to move our athletes on the floor as well. So we'll start doing more marching, so sagittal based movements, some frontal plane kind of shuffling movements, overhead kind of strategies as well. So that's kind of phase 2. Also, sorry, in phase 2, we'll be looking at maybe some concentric based adduction training and maybe moving into quasi eccentrics. Phase 3 will be then starting to attack the adductors with more localized eccentric training, manual work, or looking at bands and cables, valve slides for skater loading. We'll start to build more volume and intensity with our big compound movements with deadlifts, more like sumo deadlifts and sumo kettlebell movements, so we get a bit more adduction load. We'll also then start plyometrics. So we'll start doing ascending bounding, hop and holds, a lot of frontal plane plyometrics for control and stabilization, and stiffness development around the AB and AD ductors. We'll also put the athlete on the ice now and start to move through some basic linear skating progressions, some wide turns, pivots. And then that will bleed sort of into phase 4, which is more now growing volume and intensity. So this will be more of our max strength phase with our traditional lifts, but also bringing in heavier eccentric loading now with the adductors. Copenhagen's will come in here, and we'll try and build volume in that area. We'll introduce accelerations and decelerations and increase the plyometric load. Our on-ice load will start to increase as well with more detailed skating movements, changes of directions, increasing acceleration densities, tight turns, pivots, puck retrievals. So the complexity of the on-ice component will increase. So we'll tax the hip region, the skating musculature at a higher level. And then once we've sort of built that base, grown the intensity there, and we feel that we've achieved a lot of skating training load relative to the game load, relative to high level practices, we're looking at our external load metrics. Then we'll put them back into practice and start monitoring the chaos that they receive from practice. We'll pull back. This is phase 5, where we'll reintroduce them back into practice. We'll pull back on our volume load in the gym, and we'll select key movements, key exercises that maintain capacity around the hip region, whether it be more localized to the adductors and more intersegmental based exercises, and look to try and to introduce them into their warm-up strategy so we maintain that thread as they get back into gameplay.
Perfect.
That's a flyby.
That's a flyby, and we didn't even get close to 5 minutes, so that's fantastic. Steve, does any
just
go, mate? Go on.
Just to say on that as well, because Steve can take this one on.
Yeah.
We'll also use milestone benchmarks as we go along, based around pain, movement capacity, asymmetry, range of motion, strength, and then looking at training load metrics relative to what the individual athlete performs in games. That kind of leads our decision making on how we move them through the 5 phases.
Love that, Ed. Steve, does anything differ there for you?
Ed, you stole my thunder on the objective measures. But so that you're definitely trying to check those boxes as you go along and you stay organized. And I think the one thing I could add to that is kind of the tertiary prevention that you're doing once they're back to return to play. You know that they're still going to get a competition load spike. It's best that you try to mitigate that. That's still a challenge once they're competing. So you're seeing how those same objective measures that you're using during your rehab are responding to the competitive schedule. Are they getting a return of symptoms? Are you losing range of motion? Are you losing strength? Are you losing trunk control? Are they getting sloppy on ice? Now I'm in your sport, but on the court, those types of things. Just even though you're back, you're still trying to navigate those factors.
So, Steve, staying with you, any assessments, and feel free to use your own five-step process or whatever it is. Assessments you use during that phase to keep you on track.
To keep you on track, I mean, just like Ed said, so early on, it's going to be basic provocation tests, a couple of your key asterisk signs. That's usually daily symptoms. How is it getting in and out of bed? Are you feeling it there? Navigating, walking, are you getting it on stride? Okay, we're good with that. Is our range of motion painful at end range of motion? That's normalized. Our squeeze provocation, is that good? we're probably transitioning on to the next phase. Now we're quantifying the squeeze. How's your force? How are you tolerating some of those isotonics? Is that normalizing to your previous baseline? That's why your early monitoring testing is so important, just because if you are in a rehab setting, it's nice to know what their individual baseline is on top of their group norms. And as the rehab gets more and more dynamic, you're obviously trying to maintain those. You're probably testing those less and less frequently, and just doing those as check-ins. But then it gets challenging. I would reference everybody at the end of the paper where you're looking at how much trunk control are you gaining or losing, and how that relates to the individual's pain experience or where they are in rehabilitation. Those are more challenging, just like in the field, to take the time to quantify, to have a standardized test to do it. Do you have the movement lab to do it? Are you just doing it 2D? Those are all like more of the arts than the sciences kind of type questions. But you try to sprinkle that in as best you can, because we know how important it is.
Perfect. Top and tailed that. Lovely, Steve. Thank you very much. Right. We've got 15 questions to get through as best we can. So we've got 16 minutes and I will finish bang on the hour for these guys. So it would only be right to start from the top. However, for my safety, and I think it's, to be fair, it's something that I thought as Enda was mentioning it, how much, like you said, I think I've got the quote, athletes not listening to their own pain. And my thing in my mind was going, yeah, probably as a average athlete myself, should I have been trusted when I described what I was feeling? So coming to Alan Murdoch's question, once the athlete's in for rehab, does the original task that the athlete experiences pain in drive your process more, or is it predominantly assessment-based to try and identify location of driver and subsequent process? Enda.
Sorry, Rob, I thought you directed that to someone else. Can you repeat
Go on,
that?
mate. Yeah, of course I can. Once the athlete is in for rehab, does the original task that the athlete experiences pain in drive your process, or is it more predominantly assessment-based to try and identify location of driver and subsequent process?
Yeah, I think you will always come back to the main task. So let's say change direction, just as an example. But underpinning that will be all the things that Ed outlined as part of the rehabilitation program. So you want to try and identify very quickly which pieces of that collage are contributing to them having symptoms during that task, and then target in on that. So I would agree wholeheartedly with all the things that the guys highlighted in terms of the rehabilitation. I think the key thing to re-emphasize is that every groin is a little bit different. So it's not that they all have these deficits. A lot of those deficits are contributing to each athlete. So it's narrowing in and making sure then that, I suppose the challenging part is, number one, is that you individualize your rehab based on their deficits, not based on the injury. And then number two is that if their pain and their symptoms are not improving, do you blame the anatomy or do you blame your rehab program is missing something? And I think that's where the regular monitoring is, getting those symptom changes in that task over time. I think because the groin, it can be a bit of a Bermuda triangle when it comes to anatomy and what's real and what's not real. The default setting can be, well, we did 6 weeks rehab and they're no better, therefore the anatomy is the problem and they need to inject or do whatever, operate, etc. Versus I did my assessment, maybe I'm missing something or identified something that's not changing in my program. So I think you're looking at that task, absolutely, but then you're trying to break that task down to see, right, what components are contributing to doing that, and if I'm addressing them, I should see a symptom response.
Lovely. Thanks, Enda. The ones that we've kind of covered, I'll skip past, but we're not going there yet, so that's fine. Ed, I'm coming to you because this was your area that we started with. This is the first question that came in. What would you focus on in terms of managing and monitoring groin injury with limited equipment? So maybe give us the ideal if you've got the cash, and maybe a pared down version if you've got no cash.
Yeah, so I certainly do a provocation test at, sorry, can you hear me still?
The
phone's just going a bit lower there. Yeah, pain provocation test, just manual muscle testing and using a basic traffic light system would be a good field measure, just to see, are we reproducing any symptoms through the, through the groin or through anterior hip. That would be an easy one without any cash. purchasing a goniometer just to measure range of motion would be a nice and easy way of looking at checking hip IR, ER, and abduction, and then just trying to get some kind of basic measure of load, even if it's just session time, session RPE, training load kind of metrics, just a basic outline of how much work the athletes are performing. So that's kind of your stripped down version of it. And then I guess if you've got some money, I know a lot of teams are using force frames these days. I think they're fantastic practical tools that you can just throw out onto the gym floor to look at more bilateral strength capacities. I think handheld dynamometry, if you can get skilled with handheld dynamometry and bring that into the environment more frequently, that would also be incredibly valuable if you've got time and money. So I guess those are kind of like the key things I would focus on if we're looking at that region in particular.
Perfect. Someone's guided something towards you again, Ed. Jermaine, with regards to AB and adduction testing, most are supine at 45-degree hip flexion, given adductor magnus peak force. However, is this most applicable? Thoughts on long lever assessment, CD 0 degrees, more relevance, specificity?
Yeah, so I think the gold standard would be for me if we're looking at unilateral assessments, it would need to be a unilateral measure rather than a kind of a bilateral measure in a force frame type scenario. So we'd strive towards looking at some kind of a long lever unilateral measure, normally either supine in an abducted position or a brake test. And that's specifically important for the sport I'm in because we're looking at identifying injury risk at outer ranges of motion, normally 25 to 50 degrees abduction. But I think it also kind of holds true that even in running and cutting sports, a lot of the injuries occur when we are in an abducted position or an extended position and an externally rotated position. So I think our testing metrics are better off if we are assessing, long lever in outer ranges of motion, normally with eccentric moments. To see really what that muscle kind of tendon junction stress is and control. So that would be gold standard. However, it's the applied environment and it's often harder to bring those measures in on a frequent basis. So I think I would move away. And again, I've used hip at 60 degrees and hip at 0 degrees on the force frame, looking at isometric squeezing. And I'm more comfortable with getting better information at hip at 0 degrees flexion on the force frame than bent knee or hip at 60. So I would tend to always go more long lever if it's a bilateral measure as well, and just get a really good measure of isometric force production.
Thanks, Ed. And I think this is a big enough question to put it out to Enda and Steve as well. Anything you want to weigh in on, guys? No problem if not. Just be silent. All good? Move on? Move on. Perfect. Right. I will paraphrase this for Enda, and I'll get Steve's thoughts as well. In the future, should we focus on cutting assessments more than, I'll try to paraphrase that. Should we focus more on cutting assessments when looking to identify risk?
Yeah, I think the first thing is, movement is one piece of the jigsaw, and a cutting assessment relative to your training and playing load, relative to your anatomy or the size of your, so there's all in context. That'd be my first thing. So movement is part of that. The second thing is that if you move away from, let's say, ACL, if you have someone who has had an injury, or you're screening for an ACL injury, of course change direction is important. It counts for 50% of ACL injury mechanisms in field sport, so of course you're going to screen it. So similarly with groin, a high proportion of groin injuries off ice, so certainly on the field and court, are during pivoting motions, and so go back to what Ed was highlighting earlier, like with the eyes about every test has things it tells you and things it doesn't tell you, and once you know that, that's the most important thing. So it's when you make assumptions based on a squeeze test or a handheld test or a change of direction test, and that's not backed up then by other tests. So I think if they're describing change direction as a common mechanism, if they're describing their symptoms, certainly that's something that you should be assessing, and then working out then at a joint by joint component why they're choosing that movement strategy, whether it's trunk control, hip control, explosiveness, strength, or just patterning, post inhibition or old injury or whatever else. The large movement assessment is kind of the end piece of the jigsaw, and then you need to break that down accordingly. So I do think it's important to look at it completely. I agree. I think you take it in the context of anatomy and you take it in the context of load. But then making assumptions that my hip strength test tells me my change direction will be X, Y, or Z, or that my change direction test tells me my hip strength will be X. I think that'll lead you down a garden path of making assumptions that will limit the success of your rehab.
Perfect. Thanks, mate. Right. Another one, we maybe cover this already, but I think it's probably enough to re-emphasize. Steve, I'm going to come to you because I know you've been part of the discussion there. What strategies would you recommend adopting when groin pain is presenting in season, aside from training load reduction?
Yeah, you're going to go symptom modification. So maybe some manual therapies, modalities, immersion, all the lovely things that we can do to either just at face level mitigate the symptoms, B, maybe navigate inflammation in that whole cascade and promote tissue recovery. I think that's the biggest thing. Load is such a big parameter of that. And then depending on what the athlete's baseline is, how you train them off the field. We put so much emphasis in this discussion on testing the adductors, testing the hip musculature. Well, we got to train them too. And so that's a nuance. And when you're playing 82 plus games and 3.4 a week, you have to be creative in how you're progressively loading, when, how, to what degree. And that's why having a really enormous baseline is really high, that off-season training, that preseason training, that can make maybe some of your microdosing strategies a little bit more effective. But sprinkling that in that auxiliary training, I know that's another component of load, but you're trying to navigate all the jigsaw pieces together to make them overall more robust to tolerate that competition load. So you're just fitting it with each individual athlete to make it happen.
Great. Thank you, Steve. Next one on the list. I don't like doing this. I'll just put it out there and see, and hopefully someone will use the mic. If not, I'm coming to you, Ed. How are you interpreting the signal from asymmetries with a groin squeeze test, considering the potential inability to detect true capacity due to the bilateral deficit, but also the potential inability to detect true asymmetry due to counterforce of the opposite limb?
Steve? I'll jump in briefly while I'll pass it off. But I think that initial asymmetry finding passes you off to more testing. So Ed was getting there on how frequently we test and things like that, but they were doing a bilateral squeeze and we're unclear about the changes in asymmetry, or it's 17% or whatever it may be. Well, maybe I pop them into side lying and then do a eccentric break test, or it might be an isokinetic test where you're getting more detail. And so I think that kind of, when you're on the fence clinically in your reasoning, that's going to cue you to a deeper dive, a deeper investigation. Enda said, is it a different joint? Is it the trunk? Is it a movement pattern? But when you're on the fence and not having clear fidelity, I think that pushes us to more testing, maybe more in-depth testing, more finite, more precise testing to really get to the root cause of it, and then comparing both sides or something like that.
I think it's really important, like what Steve and Enda have just mentioned, to identify the limitations of the tests you have available to you. And a bilateral test, you can't make assessments about left to right discrepancies from a bilateral squeeze test. It has to be from a true unilateral measure if we're to make judgments about asymmetries. So then, like Steve mentioned, you would go down isolating one limb with a handheld dyno. Having said that, the bilateral squeeze can give you information about pain and maybe, one side's strength level, and maybe looking at it from an AB adduction ratio perspective, but certainly comparing left to right would be limited from a bilateral squeeze test.
Perfect. Thank you. You too. One that's come up, we usually talk a lot about AB adduction ratio. What's your opinion on adduction flexion ratio? Is it a good metric? Any evidence? Enda?
Yeah, I think again it depends a little bit on the sport. Having strong hip flexors is very important, especially in sprinting and kicking sports. It's interesting in some of the research we've done previously. The abduction to adduction ratio wasn't any different in the healthy players to those that presented with groin pain and didn't change post rehab. Now that's on a group level, so there's always problems with that when you look at an individual to it. I think having strong hip flexors is very important. I'm unaware of any particular ratio that is appropriate or inappropriate. So I would take each in its own. I think ultimately you can have very good ratios and poor movement strategies depending on how you coordinate that movement as well. So I would drift a little bit away from ratios as a good or a bad thing, or at least I have no data to back up it. Saying you need a certain amount or a certain threshold is going to leave you at higher or lower risk. But certainly being robust in each individual muscle group and then taking that into appropriate strategies on court or on ice is going to be important.
Perfect. Right. We are 30 seconds from the hour. So I'm going to take this opportunity to finish on time for once. And thank you to these three guys, to Steve, Enda, and Ed. Ed in his Maybach. I'm sure he's nice and warm. I'm joking. I don't think he's in a Maybach. That'd be great if he was. But thank you for on your various time zones and fitting me in around schedule, Ed, and you two as well, Enda and Steve. So thank you everyone for tuning in.